But the four areas where your diaphragm, your intracranial portion, your angular face, as well as phrenolus and the ligaments. Apart from that, if as I discussed, if the TLS here is going to get over, that's why you are going to initiate the patient with prokinetic support to manage the patient with this kind of GERD. And your swallow-induced relaxation, your hypertensive OAS with the sphincter, hyperthermia, as you all know, is grading of hiatus is there. So once the patient is going to land with this kind of presentation, the patient will be having evidence of your GERD. And symptoms very characteristic: nocturnal disturbances, heartburn, chest pain, irritation, not going to respond to the medications initial phase, and temporary response. Again, the patient may have coexisting presentation and sort of bitterness in the mouth. All this management is still a challenging issue, even for the best of gastroenterologists. When you're going to tackle a patient, how are you going to address, how many days you are going to treat the patient, how are you going to assess the response, whether the patient clinical scenario is being responding to the treatment or not. These are all the areas still very, very difficult to address, and so many innovations still happening in the field of gastroenterology to tackle a patient with gastroesophageal reflux. The major pathophysiological component, briefly I would like to sketch over here, is your lower esophageal sphincter competence. If your TLACR, if it is going to persist for more than 10 seconds, that means the patient is having worsening of your reflex. Apart from that, any esophageal mucosal defense, if it is going to get impact, your inappropriate relaxation of your lower esophageal sphincter, and your reduced resting pressure of your lower esophageal sphincter, and your final incompetence, as well as your delayed gastric emptying, starting from your proximal to the distal. If you have any type of physiological concept, that will predispose the patient to land with evidence of GERD. First, we have diet and lifestyle. Address the diet and lifestyle, starting from your antacids, your PPI, your prokinetics, along with various kind of molecules, your sulfate and other things. Apart from the newer molecules like the potassium competitive acid blockers and your prokinetics, all those things you can consider in the management armamentarium to diagnose to tackle a patient with GERD. But where you're going to place is still a question in this shape. So just like that, simply you should remember the brief outline about your GERD. Once the patient is having evidence of grade C and D severe esophagitis, ideally you need to start the patient on proton pump inhibitor for a duration of 8 weeks. And then because proton pump inhibitors will be having a significant potential role to eradicate, to improve the clinical scenario rather than H2 blockers. In H2 blockers, grade A and B esophagitis will be having more predominant role of response. But the role of alginates, your alginate preparation will not going to have a significant mucosal layering, but it will be having a rapid sustained response at a rate of around, once we are going to give